Now comes a little twist to the course. So things we've all along being told about which are the best options to do, why we would choose a particular case for your biomechanics, would we do ICL, what would be our enhancement approach. But there is this dreaded complication which faces us time and again, and I'm going to tell you about how we are going to look at the refractive modality, not just salvaging the situation with a mere CXL. How are you going to visually rehabilitate these patients with iatrogenic ectasia and non-ectatic disorders, non-ectatic irregularities? This was a study which was done wherein they tried to look at the way the different options of surgical procedures were adopted in US and Europe, and it was seen that up to 2007 there was a lot happening about with the blade LASIK and then on to femtosecond laser flaps. But the same scenario was there in Europe, and what happened was then there came a drop. The drop didn't mean that it dropped in refractive surgery, but the drop was acceptance of phakic IOLs and the resurgence of surface ablations which came up. And then again there was one group of patients who were found to have ectasia creeping up even in a moderate range of myopia, and that made us realize that we have to stop and look at the risk factors which are there. So these are the different risk factors which all of us are quite familiar with, right from a high myopia to a thinner cornea and to a younger age. And then came the ectasia risk scoring system, which made us look at those small skew deviations, those small challenges, a high myope, which now we would never do a cornea-based procedure over a -10 diopter, or maybe even become very conservative in going in even at lower values. But then there was one thing else which came up, and that was the percentage tissue altered. Essentially, it was seen that a PTA of more than 40%, we do not take up these patients for LASIK, is what was the claim. And we all know what percentage tissue altered is. It's essentially flap thickness plus ablation depth divided by the corneal thickness. And it had a 97 prevalence, which made it appear to be strong. Then came different papers who analyzed it and said that PTA is not just the holy grail, that you say PTA of more than 40%, you do not take up the cases, because there were hordes of cases which were done without this knowledge and were doing quite well. But then it definitely had to be put into the slot as a prime reason, prime risk factor against all other risk factors to follow. But then, as of now, yes, looking up and picking up those tiny topographic clues and looking at which could be a form fruste keratoconus, looking at overall bad D, which is something so important. You just stop dead. Do not take up these cases. And then, of course, Galilei came forward. It actually was able to pick up, differentiate between normal and form fruste even better than a pentacam display. But there were some others which came up for early detection of keratoconus, like higher order abrasions, looking at the colony biomechanics, which was discussed by Dr. Shreyash, looking at the epithelial thickness profile, and even the Bowman's membrane thickness. Corneal biomechanics, we all know that that recoil tendency or the elasticity of the cornea is lost in some of these eyes, and these should never be treated, which is an early pickup, and Corbis definitely helps to elucidate this. Just like Shreyash has told, I'm not going back and back, that this was a case in pentacam which was again reiterated in the TBI, but there are some cases where the pentacam doesn't show and the TBI shows. However, it now comes to stand that statistically significant role is placed by this TBI index. Then it became important to look at the spectral domain OCT epithelial maps, because we did come to understand that in early keratoconus or in advanced keratoconus, the epithelium overlying the cone is getting thinned out, and when you see an irregularity in the epithelial thinning or thickness profile, start looking with greater caution. Then came that if you could even pick up this Bowman's layer thickness, where there's a disintegration at the Bowman's level and the stroma looks quiet. So if you could pick up even these cases, you are picked up in early keratoconus. So these were all the preventive measures of getting into an iatrogenic ectasia scheme. Now this was a patient, we had OPSCAN at that time, not many tools. Everything looked good on the OPSCAN topography, and the patient was doing good in the right and the left eye, and comes back after about a decade with significant ectasia. At that point of time, what we thought, yes, go ahead and cross-link these eyes. The left eye was all right. Do we observe or not was the dilemma. But post-CXL, this was a cornea. The patient had 612 best corrected visual acuity, not a very happy patient. So then you realize that a management algorithm has to be evolved. When you're looking at post-LASIK ectasia, it is a complication which you have got. It's not getting rid of this patient from your clinic. It should be a patient who does not go to any other clinic but keeps coming back to you for the best answer which is available at that point of time. Would you just temporarily fit him with contact lenses? I am not too favorable. Maybe you would buy time with it, but we know we are sitting on a volcano and things need to be dealt with. So then what would we do? So yes, probably the first thing we would think of, it's a progressive case, let's go ahead and cross-link these eyes. But then there is something which you need to know. That cross-link is a mainstay for all keratoconus, but in iatrogenic ectasia, probably we should do cross-linking at the diagnosis. But then we also need to remember it's less efficient because you're cross-linking the flap, which flap does not contribute to the biomechanical stability. And there are different studies which say that there is something pathophysiologically different in these corneas. Even diffusion of the riboflavin is questionable. Then, if you have accepted that cross-linking is right, then there came this new concept of customized cross-linking, which said that it is this focal area of keratoconus which is the weak part. So if you could have energies which pump in more in this focal area and lesser in the surrounding area, that might be a good way to go. So sitting there on that concept, what do we have now? We do not have customized cross-linking in all centers. It is still there in the... So then the way to go was, if it is a central cone, you could do a cross-linking with topo-guided PRK. So early ectasia, if the corneal thickness is about 450, you are allowed to ablate about 50 micron. But we need to remember, you're only ablating the flap here because it's a iatrogenic ectasia in this particular case. So then how effective it is going to be, but then at least you have regularized the surface and you have cross-linked it, so it does make some kind of a sense. And look at this patient, he had an uncorrected vision acuity of 624, and after doing a topo-guided regularization and a cross-linking, his vision actually improved. Uncorrected visual from 624 came to 69, and that has to be kept in mind as an option to do. Supposing his cornea is quite thin and you cannot do a topo-guided PRK for him, you could even do a PTK regularization of the cornea of these eyes and then do a cross-link, and thus improve the quality of vision by regularizing the corneal surface, that's smoothing out the irregularity of the cornea. But then, if it is an eccentric cone, how would you do? Intrastromal ring segments are the answer for this, whether it's an ectatic eye or a non-ectatic eye. So post-LASIK ectasia too, it has a role to play. You need to have a clear central cornea and a steep keratometry, no doubt. And these are eyes where the BCVA is not doing too good. You can't do a topo-guided PRK and solve the solution. You need to enhance its quality of vision because the cone is away from the physiological position. So the same standard things come in. You need to look at the spherical equivalent. You need to look at the location of the cone. You need to know how much astigmatism is there. Are you going to place one ring or are you going to place double ring? So then to know first whether it's a centered cone, if 50% of it is within the 3 millimeter area, it's a centered cone. Then you place symmetric ring segments and just position the eye. And if it is an asymmetric cone, you would just use a thicker segment inferiorly and a thinner segment superiorly. And in some cases of pure cylinders, just place the inferior segment alone. So essentially, let's remember that a double ring gives a global effect, whereas a single ring gives a focal effect, which is needed in eyes with pure high cylinders. So now look at this eye now. We have come back to that eye pre-intax. He has this kind of a centered cone. So post-intax, this incidentally, his vision came to plano 6.9, which was a dream. We cannot promise so much to our intact patient and a post-LASIK ectasia at that, but definitely doing this and cross-linking, if you could do it at the same time, now with the understanding which we have, it is pushed to its physiological position, and then which improves the best corrected vision, and then you can cross-link it and combine the both. You could even go ahead and do a contact lens fitting after intacs, but it's just buying time temporarily. So then what do you do with those residual errors which come in after having done CXL and intacs? So if it's a road residual error, they say that you could do a topo-guided PRK, but let's keep in mind there may be more haze here, and there may be epithelial hyperplasia along the channels, which has to be kept in mind. But if the residual error is more, after having done intacs and cross-linking, then you could place phakic ICL in these eyes. And believe me, you have to wait for 6 months. It's a two-step approach. You need the topography to regularize. You need your refraction to stabilize. And if your anterior chamber depth is good, you could do a phakic ICL. I'm not showing the thing for the paucity of time. So then when all these algorithms are going on, you are stuck in a situation where the corneal visual axis itself is not clear. And when the visual axis itself is not clear, then the next step is, we need to look at DALK. So then, when we look at DALK, it may be a good surgery to do, but let's remember, we are challenged with sutures and how you are going to rehabilitate the patient. Would you do a topo-guided PRK on top of it? Would you do a phakic ICL on top of it? So, but what I would like us all to go back understanding is that there are a wide range of treatment options which are there. And if we look at all our iatrogenic ectasia patients as patients who need the same kind of vision which you had promised him before you did LASIK, you could work out different combination therapies and optimize his outcome. I thought I have 10 more minutes. 10:30 it gets closed. Huh? Yeah, so I'll just show one or two non-ectatic irregularities. I'm not going to explain it too much. This was a patient who had a epithelial ingrowth peripherally. Actually, it was within 2 weeks after primary microkeratome run elsewhere. So primarily, we did an interface wash with mitomycin, which was placed there. And then the topography was irregular. You can see that irregular flattening, that green on the sagittal curvature map. So now, and a significant astigmatism. So then all we did was do a topo-guided regularization where you remove some amount of tissue on the opposite side, which is called a bimodal approach of doing a myopic and a peripheral hyperopic ablation. That is, you are flattening the steeper area and by doing a hyperopic correction, you're steepening the adjacent area so that you are making the cornea more irregular, and this is how the patient's cornea became. This is again another situation which I'm going to show you. This patient was treated long back and had a low hinge with significant mixed astigmatism. You can see on the sagittal curvature map that green zone which shows you the flattening. So again, you could do a topo-guided regularization for him and see he is significantly improved. This is the last of the case which I'm going to be showing you. This was a patient primarily an opti-LASIK, had a free flap. Incidentally, the limbal to limbal orientation of the flap was not done. He had a significant astigmatism. And again, in this patient, you could do a topo-guided regularization. Sometimes it's a two-step approach. First step, you have regularized the corneal topography, as you can well see on the sagittal curvature map. And then you could correct the refractive error after 6 weeks, doing a wafer-guided option and get him a plano 6/6. So essentially, as we all refractive surgeons stand today, it's the challenge of the hour which challenges us to greater learning. And believe me, I think as refractive surgeons, we can give them the best even in the most complicated situations.